Have you heard of the Business Busting Concordat? Well, you may not have done because this was a document released about 6 weeks ago by the Department of Health and Government, and it's basically designed to try and support general practice with tackling bureaucracy. I know, I haven't heard about it either. Well, don't worry about it. In this episode, we're going to cover exactly what it is, how it may affect you, and more importantly, other services in the area to help improve patient care. Let's tech enhance your primary care and learning. Hello, EGP learners, and welcome to this session where we're going to be talking about the government's Bureaucracy Busting Concordat. It's a bit of a tongue twister, isn't it? And it's a really interesting document that we've come across that I don't think many people have really heard about. And when we've had a look at it, it seems quite interesting, doesn't it, Andy?
Yeah, it seems quite interesting and sensible. So this document was referenced in the letter to general practice on the 26th of September, outlining those changes to IAF, to ARRS roles, PCN DES, and what the ICBs need to be doing to understand the challenges in general practice going forwards. Got a good video on that. Have a look at that. That was last week's video. But they referenced this document in the area about reducing bureaucracy around the transfer of patients and care and information between primary care and secondary care. So we thought we'd take a look. It's a little bit old. It's 23rd of August. The way it's named sounds like it might be one of the sort of last dying acts of the Boris Johnson government. Bureaucracy Busting Concordat. Sounds a little bit Johnson-esque to me, but interesting. And we looked up what a concordat was, didn't we, Gandhi? What did we find?
So, according to the definition, in terms of British English, it's an agreement sent between a pope or the Vatican itself to a secular government, outlining the changes and wishes and stuff, which we were slightly confused because obviously this is from our government to other organizations. Now, interestingly, in American English, it is considered to mean a compact or a formal agreement as an alternative meeting. But yeah, we've used slightly different definitions here.
Yeah.
We just find it really interesting.
It's an interesting word, isn't it? I say it does sound a little bit Johnson-esque because it's a little bit grandiose. Why not just say agreement? But just got me thinking about the word concordance as well, because when I was at medical school and when we used to talk about our patients taking their medicines as prescribed, we used to use this word compliance, which was, are they complying with the prescription? And then at some point during medical school, I think that was felt to be a little bit top down, a little bit physician led, and we should be more in partnership. So we started talking about, are they concordant with their medication? And apparently concordance can mean the agreement between two naturally complementary data sets. So it's like, is the same thing or the same data held in one place as another? So we talk about concordant twins who share genetic information. So it's really nice. So is the idea about, is the data held in the head of the physician about what medications are being taken the same as that in the patient? I thought that was really nice. But that's the word concordat and concordance.
So now that we've had a little bit of an entomology discussion, we're now going to talk about the actual concordat itself. And it comes from some of the original work that was started about 2 years ago in 2020. So during the pandemic, when there was an absolute recognition that general practice was actually doing a lot more than people thought it was doing, despite what certain parts of the media continue to peddle and stuff, that actually there's a huge burden that was causing an impact in terms of the patient service and the availability of clinicians in terms of helping care and stuff. So the government task force was asked to look at this and see what they could do to try and tackle and change things and make it more sensible, particularly for other organizations to understand how to engage with general practice, and more importantly, when to engage with general practice about certain things, and then after that, how. And that's basically what the Concordat sets out in 7 key principles, which we're going to go through in a second. Was there anything else you took from that particular background part, Andy?
Not really. So it represents an intention to reduce the burden on general practice, and I think it sits alongside work that's going on between is it the Joint Association of Royal Colleges? What do they call where all the Royal Colleges get together, Gandhi?
The Academy of Royal College, something like that, isn't it?
So I think the RCGP, the BMA, the Academy of Royal Colleges, I think have all been doing work, and I'm not sure that's directly referenced within this government webpage, but I think it sits definitely alongside that, and the intention is to reduce friction, reduce burdens between primary and secondary care, and an intention of that is to reduce the workload on GPs so that you can release time for them to do the day job and see patients, which is really
Well, it's
noble.
interesting, Andy. I actually think this one in particular makes more reference not to the primary secondary care interface, but actually more around other organisations, so particularly government and departmental organisations with primary care. And when you go through some of the more detailed aspects of it, I think that's definitely where a lot of this is interacting. So particularly, I think with things like local authorities, other types of organisations, I think that's actually where this document is directing a lot of the stuff through. The primary secondary care interface is a key part that we covered previously in our episode about the consensus of primary and secondary care interface by the Jersey. What was it?
There was an LMC, wasn't there? That had produced a really good document on that.
Cheshire and Merseyside, that was it. Yeah.
That was it.
And that focuses very much on the primary secondary care interface. This, I get the impression, it is talking more about other types of organisations, so housing, job centres, local authorities, safeguarding, that kind of stuff. I see that very much what this particular document is directing to, which is a significant amount of workload, and really interesting to see whether this will also apply to private stuff, so in particular insurance forms and things like that.
So it does talk. So it talks about government departments who follow the Concordat, and it uses the language of departments. So you're right. That is different and additional to that other work that's been going on between Royal Colleges and medical professionals, and it could make a real difference actually, because I've seen things move in the opposite direction in recent weeks. Yes. I don't know if you've noticed this, but actually we are probably getting more requests from patients for information to support various applications or processes that occur within local and central government around DWP, around the DVLA, and around local government things like blue badges for disabled parking permits, and things like that. And it seems that, well, I get the impression that some of these departments are perhaps getting an influx of applications, and they need a way to quickly discriminate and prioritize things. And a very easy thing for them to say is, we can prioritize you if you get a letter from your GP saying that this is the intention. And, that helps their process, but it actually produces a whole lot of work for general practice. And, hopefully if this helps reduce that and makes government departments think about the impact on general practice in the healthcare system as they design their processes, that will be a good thing. But anyway, there are 7 principles. Shall we go through them?
Yep. So principle number 1, all policy should be designed with the patient and the patient journey at the heart of the process to ensure minimum administrative burden for people accessing government services. So the key thing, I think, is it's putting the patient at the heart of it, which is definitely an important step, I think, and making sure that actually the focus of this document and various other processes needs to be about making sure patients get the right service at the right time.
Yeah. There's a danger that discussions of this nature become a little bit focused on the priorities of general practice, focused on the priorities of the department. The patient could get lost. So I think it's very important to set out from the very beginning to put the patient at the heart of it. So that feels really, really sensible. The next point I think is really, really important. So general practice should only be required to provide evidence of medical nature where it is unavailable by other means, which I think is really, 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 really good. And then it further, it says to make sure that to consider why they're actually asking for factual medical evidence, and is that required? Only request it when it's necessary. Only request the detail that is necessary, and only request it as often as it is necessary. If you've already been told that something is permanent, maybe you don't need to require an update on that, every year or a few years, for example. So I think that's really, really important and really, really quite impactful, actually. And I know sometimes I'm asked, often by patients, for supporting evidence when actually somebody else will have given the same evidence, perhaps in more detail. They might have an outpatient letter from their cardiologist or whatever speciality it is that would probably serve the purpose to demonstrate their disability or their deficiency or their problem perfectly well to the local authority, but they still feel they need a letter from me, or it's still asked for. So if that removes those sorts of things, that's fantastic.
Absolutely. I think it's trying to tackle that whole GANFID culture. So GANFID stands for get a note from your doctor, which is absolutely a thing within the medical profession in terms of a realization that actually it's very easy sometimes for somebody else to say, go get a note from your doctor to deal with this. As you mentioned, Is it a way of prioritizing need? Often, I'll be honest, it's just a way of creating a block for people to access a particular service, and therefore that's why it's created. And it's good to see that actually there's the recognition that shouldn't be happening in a lot of situations with that particular point and stuff. It then goes on. Go on.
It outsources the work to general practice, really, to prioritize people.
Yeah.
I think it's asking not to do that. Sorry, carry on, Andy.
No, not at all. So number 3 is when introducing or reviewing existing requirements for a medical certificate or examination, ensure the most appropriate professional for the job be able to certify, promoting alternatives to the GP, including other members of the primary care team wherever possible and appropriate. I can definitely jump in on this one, Andy, unless you want to go first.
Well, that sounds perfectly sensible. It doesn't always need to be a GP or a GP signing things, and often other people know the patient better. Other people are professionally better placed. So, for example, our practice nurses managing long-term conditions around breathing and endocrine issues often spend a lot more time talking to patients, and they know the patients and their status much better than we do. So why ask us to sign a document? Similarly, physiotherapists, for example, will have a much better understanding of somebody's mobility and physical function, for example, than we do. So we're not always the best people. Make sure the best people sign it. But what were you going to say, Gandhi? What was it?
Well, I think there's a couple of things to consider here. So number 1, it mentions the fact that it doesn't have to be the GP that does the actual documentation and stuff that you need if you were to need something. We're definitely seeing a shift away from GP specifically doing a lot of the administrative work around this. And I think it's also reflected on the later points. The bigger one is it talks about certification, and actually one of the changes that has already come into play is the changes to medical certification in terms of fit notes. So actually more professionals are now able to provide fit notes to patients, including pharmacists, physiotherapists, nurses and paramedics. So as long as they've had the training, they can now provide fit notes. So it is already happening, some of this stuff in particular. And absolutely, as you mentioned, your hospital-based clinicians can provide that in terms of the documentation when appropriate. So it doesn't have to be the GP that provides the documentation. That part was already there in terms of hospital doctors doing it. And if you don't believe me, we will definitely link you into the video that confirms all of that Andy's watched earlier this morning that I made, which I had a lot of fun doing, to be honest. Yay. But I think it's just important to recognize the fact it doesn't have to be the GP every single time, which is what this point is clearly identifying and referencing and stuff.
Yeah, and then absolutely agree. So point 4, when requesting medical information, ensure standardized forms are available for use and ensure that all information requests are as clear and concise as possible. So again, it is what it says on the tin, but often we are just asked for, a letter or evidence. Often we're asked in a very unusual way in terms of they ask the patient to get a letter to get to them, and it's not quite clear what information is actually required. Sometimes the patients jotted down, they say, oh, if appropriate, this particular phrase or wording needs to be there, they've told me, to have the desired effect, all sorts of strange things like that. So actually just having proper, concise forms that ask for what information is required would be really, really sensible whenever government departments are requesting information from medical professionals, including GPs. So that just sounds really sensible. And together with asking for the minimum required information at the minimum frequency, that would really create a lot.
Absolutely.
A much better experience for patients, which is priority 1, and reduce the burden for us. So it feels like a no-brainer.
Well, it's like we mentioned, a standardized process of asking for the correct information is essential for this kind of thing. Otherwise, you may end up having letters that waffle off and give no detail, or ridiculously short ones that, again, don't give the relevant information that helps people make the decisions when it is appropriate to find that information in the first place. So I think that's the other part about this. That's why standardized forms can be useful. But more importantly, standardized not just from the service itself, but across services as well. Actually, why do we need to create multiple different forms for each different organization and stuff, when actually often a lot of the times what they're after is the same type of information? We'll come to a way that I think a lot of this can work so much more effectively from next month in the later section and things. But I think, important to recognize it is very much talking about standardized information and things.
You know what, Gandhi, that's just such a really good thought and idea, because, for example, if there was a sort of a, government mobility form 1, GMF 1 or something, if you filled that out for the Department of Work and Pensions, if another agency needed similar information, Could they not just ask for a copy of it? You'd already have done it. Maybe they can even share between departments, although I appreciate that there'll be lots of consent issues potentially around that. But
there's a way around that coming up. But yeah,
standardizing the process would be quite helpful, wouldn't it, to create duplication? I like that thought and that idea, Gandhi.
Mm-hmm. So that when we're talking about forms, it talks about that in number 5. So always consider digital forms rather than paper-based approaches, with standardization and the potential for automation of data sharing where appropriate. It's like we just said it. Though digital solutions in themselves may not always reduce bureaucracy, I think there's nice there's a recognition. Where possible, these solutions should be integrated into the general practice systems. That for me is possibly the most significant piece of information I've seen in this Concordat, and actually kudos to them that have come up with this. That is just how it should be.
So I guess, Kenny, what the meaning by that is that there might be on system 1, we might be able to, for example, fill in the government mobility form 1 on there, and then we can provide that to the government. They can share amongst themselves, but at least it's filled out there. It could even be pre-populated, couldn't it? With using some of the read or SNOMED codes from within our systems to help it be done really, really quickly, and probably not by the GP, but by another member of the practice team. If the information is clear and factual. So so I like where this is heading and where this is building. And the next point 6.
Well, if I may, Andy, so a key organisation I would definitely recommend that this Concordat needs to be sent to in triplicate, is the DVLA, because actually the DVLA forms that we get are horrifically poor at being able to be completed by general practice because they're just so unuser friendly. They very much are paper-based forms. You can't have the digital versions and stuff. And actually the boxes that are allowed to fill in the information are tiny, for lack of better terms, and you can't fill in a lot of the information appropriately because it ends up looking like a poorly written scroll. We all know the jokes around doctors' handwritings and stuff as well. So actually, why would you not want a proper filled in form, particularly something that is life-changing in terms of somebody being able or not able to drive? Additionally, a lot of that information can easily be imported with the right templates and stuff from the GP record automatically, and it's the same form nationally. It doesn't change. So make it happen. This needs to be sent in triplicate, like I said, to the DVLA, and actually it would improve the experience for so many people out there currently because of the significant backlog after they cannibalized their medical workforce and transferred everything over to general practice, because let's be honest, that's what the government does sometimes for their organizations.
To be honest, the DVLA is already part of the way there in terms of at least they have standardized forms for different medical conditions and indications.
Yes. Just digitize it. It's not that hard to do.
Yeah,
it really isn't.
I mean, I pay for my road tax, and the DVLA have some good online forms and ways to engage with people. So it may be that they're a good candidate to be an organization that champions this and maybe leads it, because other organizations could potentially use or borrow some of their forms. Very interesting. The next question, the next point 6 is about where possible co-design these forms with general practice. And that sounds really interesting. I know through we're doing lots of work on sort of co-designing our primary care network roles, Gandhi, and actually it's very clear you do get better outcomes if you test what you're doing at an early stage with the people that you are working with that are on the other side of whatever arrangement or process you want to happen. So that sounds really, really important. They want to make sure it does what it needs to do, that it's user friendly, and that there aren't any snags with it that the GPs might see that are not obvious to the people who are leading the design of these forms.
Absolutely. And I think this is one that I would very much recommend the ICSs in particular take significant ownership for when we're talking about engagement between local authorities, councils, various other local based organizations. This absolutely needs to have the input of the general practice perspective. So ideal organizations would be the LMCs in particular to focus on a lot of this kind of content on. So for those that are watching this don't have a clue what an LMC is, that's the local medical committees. They are regionally based on different parts of the geography and stuff, and they will absolutely be supportive in trying to help understand how best to make this side of things work effectively for your local area. In terms of the national ones, to be honest, that they have people that they can easily on board with supporting this, because actually they should do, there should never be a form that's asking information from the GP record that doesn't have a GP involvement, because actually, do you understand how that's going to work effectively or not? Without that, just saying I want X, Y, and Z may not be appropriate and stuff. And then the last one, and this I think is a really potentially interesting one. If only medical history is required, where appropriate, make the provision for the option for the patients to provide this themselves rather than requiring it from a GP or health professional. Where possible, this process should be designed without the need for GP certification. Why is this significant? Well, as of the end of this month, patients will have prospective access to their medical records. So actually, the number of patients that can prove directly that they have whatever condition they're saying, yeah, it's going to go up significantly. And actually, patients definitely will have access to this information and the information to share if they choose to. And obviously, this may be an option for many people to direct how to share information appropriately and remove the need for any form of certification from general practice.
I think this is really significant. I also identify that these organisations or the Department of Health may need a little bit of medical input to make sure that their processes are suitable for this approach, or they may not be confident to take this approach without a little bit of medical input. For example, they may need to understand how different medical conditions that may be coded in patients' notes, will affect them or are likely to affect them. So I can imagine that actually if they have appropriate medical input to enable them to interpret properly the data that they get coming through from patient medical records, then with those steps in place, you could certainly eliminate the need to request information directly from GPs or for GPs to interpret the information, because often what they ask for currently when they ask for information is not just the list of the problems, but they want to know things like, is that a permanent problem, or is it reasonable that this problem would affect them in the way that they describe? They're asking for judgments, and that's what they currently feel they need from medical professionals. But actually, they could be given some guidance documents to enable them to appropriately interpret the information they've got from the patient and from the medical record, and only ask for further information where it's absolutely necessary, where there's genuinely some uncertainty about the impact on the patient. So I think we need to be prepared, I guess, some of us, and the LMC is a good place to start, and the BMA to help, I think, government with this as well. But it'd be very beneficial.
Yep. And I guess it's really important to understand the challenges that we're going to see with some of this. So, theoretically, well, not theoretically, actually, this is now an available document that's, in terms of sharing information and stuff and how to do it across organizations and stuff. It then does talk about the potential outcomes. And I think this is important for us to consider and look at in terms of how this will move, because it recognizes culture change in particular doesn't happen overnight. We know that. And actually, that can be a really complicated process to go through. But it does talk about, the aspects of it being co-designed with representatives from both sides of the, whatever information sharing aspect it is, and that should be happening moving forward. Also, other professionals being able to support, and we've seen this in some of our earlier episodes where we talked about other roles increasingly having more involvement in this side of stuff. So we talked about the pharmacists, the nurses, the physiotherapists, that kind of stuff. GP assistants, non-clinical roles, I think, can have real benefit, because actually a lot of this paperwork stuff doesn't have, again, as we've mentioned a few times, doesn't have to be filled in by the GP. It's just data extraction from the records and stuff. And they want to see a positive impact on this. They're going to continue looking at this with a view to seeing how this is actually happening. They have given some examples. So the isolation note that came into effect with COVID, the initial 10 days that people would need for certification for work when COVID first hit, they did move that away from being GP's or practice responsibility, because actually if that had been coming through to general practice, we would have been inundated, absolutely inundated, and actually then we wouldn't have been able to provide any of the type of care needed during the peak and the troughs of the pandemic and stuff. I mean, what did you think about that, Andy?
Yeah, it was. I mean, that was a huge help. To be able to direct people to places where they can, essentially in many cases do their own isolation note. That was really, really, really helpful. I was also just looking at this. I think it's really good here that they have, defined some success criteria. So that they know they've stated what will be happening if this concordat is successful and it's being followed, and that people are receiving the information that they need in a prompt time, reducing the impact on patients in terms of waiting, and improving general practice job satisfaction, retention, and role attractiveness is also a desired outcome. And I think it would contribute to that at least. But it gives the opportunity to revisit this, and they can see whether those things are changing and whether we feel that there's been movement. Yeah, on the whole, I think this is it's really good that the Department of Health has published this document, that they've got their eye on this, and that they're demonstrating that they're aware that actually the behaviour of local and national government departments has an impact on general practice workload in particular, and they want to do something about it, and they're attempting to provide guidance for their departments and agencies to make this situation better. So I think that's really, really quite positive, actually. What do we do with this? And I'm wondering if I might start writing back and replying to unreasonable requests, directing them to this Concordat potentially.
Or I think there's possibly some involvement here from our LMCs to actually say, here's a standardized letter for you to share with organizations when they've asked for inappropriate information, for you to both share with the organization and with the patient as well, that actually this is what should be looked at. I think there's also absolutely involvement of the ICSs in terms of looking at this and actually changing things locally. So with the various different aspects of interface with local authorities, other organizations, community partners and stuff, actually, this needs to be on the agenda at the very least in terms of tackling some of those workflows and what some of those requests and stuff. And once that starts the discussion, helping to inform patients actually, getting the information, it can be important, but it's, equally important that the right information is sought from the right person at the right time.
Yeah. And also, there's a little bit of ask on general practice here, isn't there, to play our part in the discussions and the co-design. So we need to be prepared to step up to do that, to put in a little bit of work now, I guess, to reduce the workload longer term. It's about a few of us doing a bit of work now to reduce the workload for a lot of us in the months and years to come. But a nice positive story compared to other weeks where we're often sounding a little bit negative. So it's good to end.
I'd be keen to hear from our EGP learners what they think of this Bureaucracy Busting Concordat, at the very least what they think of the name. But more importantly, how are you going to action this in your local area? What that we've mentioned there is a responsibility in some way of general practice to help push this agenda forward, because actually by doing so we may help improve the work lines that we have down the line and stuff. How are you going to take this forward? Let us know, and let us know down in the comments as well. If you have found this useful, absolutely leave us a like wherever the button is, somewhere down below. And as usual, we're here to help tech enhance your primary care and learning. And we'll catch you in the next episode.